This is the first of a set of symposia that we have as part of the conference, and I'm delighted to have been asked to introduce it. The lineup of speakers that we have really is indicative of the nature of the project. So when NCHAP first started 20 odd years ago, it was unusual in that the initial set of investigators, the composition of the investigators was unusual in that it had 2 sociologists, 2 physicians, and 1 other person. The other interesting thing about the composition was that it did not have any economists. And I think if you look at the way in which the project has developed, that shows the influence of these different groups in a very interesting way. First of all, the cooperation across disciplines between the social sciences and the medical sciences. This was illustrated by what William had to say earlier on, to have something that looked both at the social nature of people's aging and the technical or medical elements of their aging was unusual, and that both of them were respected within the confines of the project. In other words, the social scientists listened to the doctors. That's perhaps not too unusual, but the doctors listen to social scientists. That's perhaps a little more exceptional. And our speakers in this session epitomize one aspect of this collaboration, which has been really exciting in the way in which it developed over the years. The strength of the biomedical side, the strength of bringing together not just the measurement, but also the implications in social terms of what was being measured, I think is what makes NCHAP exceptional. So we have 3 speakers. They will speak one after the other, but I'll introduce them all to begin with. Jay Pinto will be our first speaker. Jay is a professor of surgery here at the University of Chicago, and he is our smell expert. He has a much more impressive technical description, but that's really what it comes down to: sensory perception and its implications. And one of the more exciting findings we've had, and Jay may talk about this, has been the importance of smell, the importance of olfaction in terms both of predicting what's going to happen to people and also the quality of their lives at the time if it deteriorates. We were delighted when Jay came on board. He really strengthened enormously a whole area which is difficult to measure and has rarely been measured in surveys. So NCHAP is unusual in that it measures all 5 senses in combination with the other characteristics that we look at. Elbert Huang will be our second speaker. Elbert is a diabetician, if that's the right term, but also a public policy a public policy person, and epitomizes what we think of as a really important combination of medical expertise and an interest in society, so in public policy. Elbert is a practicing physician as well as a researcher, not just in his own special fields, but also in public policy. And Dima Qato is a pharmacologist, and I think one of the things that paid off more for NCHAP than anything else that we did from the beginning was to include in our collection of data medication log for the respondents in the survey. So this was really unusual and indeed almost bizarre at the time when it was introduced that we would do this. First of all, even to be able to do it, I don't know how many of you take medications. I suspect it's strongly correlated with age. Could you tell, when I go to the doctor following William's advice, not very frequently, when I go to the doctor and they ask me what medications I have, and I tell them, it rarely conforms to the electronic medical record. Who knows which is correct? But we have been collecting medication logs since the beginning, and Dima has been our guru in this area, and a lot of really important results have come from this. Again, it relates strongly to what William talked about, the fact that in the biomedical model, people look at individual drugs and what they might do. It's the combination of drugs and the combination of drugs with the combination of vulnerabilities that's perhaps much more important. And Dima's work has been fundamental in addressing this question within NCHAP. So with these inadequate introductions, I refer you to the hard copy documentation available if you want to read more detail about what our folks do. I would like to ask Jay to come and speak first, Jay, unfortunately, has to leave immediately after he has spoken. I mention this only because otherwise you might think he's leaving because he disagrees with what Elbert has to say, which is not in fact the case. Jay?
Okay, great. Thank you for that very kind introduction. And I will say, maybe the most fun about these project is the opportunity to work with so many different kinds of people. It's really super interdisciplinary. It really has fostered a lot of intellectual growth, I think, among all the investigators, most of all me. And I'm really grateful for the chance to work with so many smart people. I'm going to talk about smell decline. The title of the talk is Signal of Aging and Consequences. And I'm a rhinologist, so I take care of diseases of the nose. And I hopefully, through the end of this talk, you'll understand that your nose has a lot of importance in your health. So this is a picture of a candle. It's a fancy $72 candle made in France. And people buy these $72 candles. Maybe you have some candles, maybe they're not this expensive, but people buy candles. And I want you to think about, why do you buy candles? Why do people buy scented candles? Sure, to mask bad odors. Any other ideas? Make you happy. That's right. It makes you happy. The people like scented candles. And you might be amazed to know that the scented candle market in the United States is $4.22 billion per year. Okay, so it's hopefully that's buying a lot of happiness. And as you were suggesting, economists are pretty smart, right? So economists would tell you that there's $4.22 billion worth of value for people in scented candles. And so you have to think about, look, why is that? Why do smells make us feel good? Why do people buy candles? Why is odor so important? Well, the sense of smell is really important, as with other senses as well, because it allows us to interact with the environment, right? We use our nose to detect what's in the environment, and it actually influences us. And that's a really powerful connection between the environment and our brain, and it's mediated by this sense, the sense of smell. So what are the functions? Why is it so important? Why do people buy so many candles? Well, odors are involved in perceiving pleasure. They mediate the sensation of flavor. So food tastes the way that it does, mostly because of the sense of smell. It allows us to detect danger in the environment. If this building starts, if there's a fire, we're going to smell it first. So we can detect smoke, we can detect toxins, we can detect spoiled food. It's important in memory. So all of us can remember particular odors from our childhood. I'm giving the example here of your grandmother's cookies, right? If you close your eyes and you imagine that, it takes you back, right? All the way back to your childhood. And it affects our emotions and our mood, just as Megan said, like it makes you feel good. And that's why aromatherapy is a huge market. That's why people go to spas and put fancy odors on their bodies, because it affects our emotions, and affects our mood. And so all of these things are a critical part of our lives. And maybe one of the reasons why these things are so fundamental to how we are as people is that the olfactory nerve, which is in the roof of your nose, is directly connected to your brain. So it is a part of your brain that's out in the environment, in your nose. The nerve fibers go through the bones of your skull and they plug right into the brain. And when I say plug right in, unlike the other sensory nerves of the head, they don't go through a processing center called the thalamus. They go directly to the parts of the brain that are important. And those parts are the orbital frontal cortex, which is involved in decision-making and emotional processing, the amygdala, which is involved in emotions, and other parts of the brain that are involved in memory. And Patricia, please forgive my neuroscience slimmed down version. So this is a very complicated circuit, but these are these fundamental processes. So if we go back here, well, it plugs into the place that's involved in pleasure. It plugs into the place that's involved in memory. It plugs into the place that's called emotions. And that's why these things are so important to us. And that's why they have a big effect on our lives. So those things in turn are involved in how we live our lives. They're involved in eating. So when you can't, when your sense of smell is impaired, you have difficulty detecting spoiled foods and smoke and gas levels. 33 or 40% of people can't detect the odor in natural gas, so they can't detect a gas leak. It's involved in eating and cooking, and so you don't have pleasure in cooking. You don't know if the food tastes good. You're not interested in eating. People lose weight. Personal hygiene, things like not knowing whether you need a shower, not knowing whether your house is clean, a lot of anxiety around that. Hard to clean, hard to buy fresh food, hard to interact with other people in terms of going out to eat, enjoying social functions that are around eating. And so this leads to reduced weight, appetite, decreased well-being. You can be involved with depression, and I'll show you some information about that in a second. And then overall, you have a decreased quality of life, decreased ability to sense pleasure, and that really affects your lives. So, we have this wonderful opportunity to study this in NSHAP, where we have a large number of people, nationally representative people all over the country, where we have lots of information about their social life and their health, and we can follow them over time. And we have also sensory function. We have all 5 senses in the first round, and then we have olfaction in all the rounds. So we can actually look at how people's sense of smell changes over time and see how sensory function plays a role in people's health and social life. And so we measured the sense of smell with odor embedded markers. These are like markers that you may have grown up with in school that have odors in them. And we present the marker. This is a nice picture of me holding a marker here. It's the only one I could find. We have these 5 odors, and we give the patient we give the subject the pen, and then we ask them, like, okay, what does this smell like? We give them some choices, and then we can categorize how many do they get right? 1, 2, 3, 4, or 5, and we can rate their sense of smell with no sense of smell, decreased sense of smell, or good sense of smell, normal sense of smell. So first, I'm going to talk to you a little bit about what we've learned about risk factors for smell loss, and then at the end of the talk, I'm going to talk to you a little bit about the consequences of smell loss. So what are some risk factors for smell loss? What are some things that we could say, okay, these are the things that predispose you to sense of smell? Well, one of the first things we did was we just did a very simple plot here of odor identification. So these 3 graphs here you see on the top, the dotted line is whether you get 3 or more right, the next one is 4 or more right, and the one on the bottom is 5 or more right. And regardless of how you count how good your sense of smell is, you can see on the bottom that as people age, their sense of smell, their ability to choose these odors correctly, identify these odors, something we call odor identification, declines. So right there, we know that age is a big risk factor. This has been described by others, but aging is closely related to decrease in the sense of smell. And we all know this. People's vision goes down with smell, with age. People's hearing goes down with age, and smell is another one of these senses that declines with age. It has a big impact on our lives. Okay, what about environmental factors, right? I explained to you that this is a part of your brain that's right here in your nose. Like, I can take a little camera and put a camera up there, and I can see that area in the clinic. And that olfactory nerve in this cartoon, you can see here, it's at the roof here. And these nerves, as I mentioned, go through the skull and go into the brain. And so the olfactory nerve is actually directly exposed to the environment. And therefore, it's susceptible to anything that we breathe in. We saw that in COVID. It's susceptible to viruses. And it's also susceptible to pollution, so airborne pollutants. So in animals, it turns out that you can actually do studies where you radio label particles and you put them in the nose and they end up in the brain. They're getting to the brain through the nose. And the question we had is that true in humans? And is pollution potentially a risk factor for not only olfactory problems, but actually brain health as well? And so we were able to collaborate with a colleague, Helen Sue, who mapped pollution exposures. We know where these people lived. As William mentioned, geography is very important. It came up in the questions. So we mapped where people lived, and we were able to show that people who had higher air pollution exposure had worse sense of smell. And this is adjusting for all the other factors that might affect their sense of smell. And notably, I should also mention, that's not on the slide, but the average exposure of particulate matter pollution was about 14, and the WHO limit for pollution is 10. So on average, older adults in the United States are seeing higher levels of pollution than is recommended to be safe. So pollution, what you breathe in, is a risk factor for your sense of smell. Okay, what about genetics? Genetics is inherent. I hate to go for the biomedical model here, but there is something to genetics. We have some genetic data on these respondents, and we found that this variation in this gene, ApoE, which is a gene involved in Alzheimer's, one of the risk variants called E4 is associated with worse sense of smell. So the more copies of that variant that you have, the worse your sense of smell is. So we have aging, we have environmental effects, and we have genetic effects. And in fact, we found something interesting, which was odor identification was worse in these people with E4 carriers after age 75. But if you measure not just here's the odor, what is it, can you name it? So odor identification. But if you just measure, hey, I'm going to give you an odor, it doesn't matter if you know what it is, can you detect it at what concentration? Something we call threshold. So if you have a good sense of smell, you can detect things at a very low concentration. And if you have a poor sense of smell, you need a very high concentration to detect that. And in that case, the E4 carriers, we could detect those changes at age 65, indicating that some of these effects from genetics are starting even earlier than for odor identification. So genetic risk is another thing that affects the sense of smell. And these E4 carriers also, their sense of smell declines faster over time. Because we have the ability to follow people over time, we can measure the rate of change. And we think there's something important about that rate of change in terms of accelerated aging. They have accelerated sensory aging. And the question is, do they have other consequences of that accelerated decline in their sense of smell? Okay, so that brings us to the last part of the talk, which is consequences of smell loss. Okay, so I've explained to you the risk factors. Some of those things we can't change, but can we look at what happens to people? Because now I'll turn to the social model. We may not have treatments, but we can still help people. And even if we know what's going to happen to people, especially at their age, there's lots of supports we can provide them in their lives to help mitigate some of the problems that they might have in their health, and in this case, in their sense of smell. So I told you that, olfaction's been related to depression, but nobody's been able to figure out whether people with poor sense of smell are depressed because they don't have a sense of smell, or is it that the reverse could also be true? You're depressed and there's a problem with your brain, and then you get problems with your sense of smell. So which comes first, the chicken or the egg? And this is something, again, we can answer in NCHEP. We have this wonderful resource to look at people over time and see what happens to them. So in this case, we looked at people who had olfactory dysfunction at the baseline, and then we figured out how many of those people developed depression over time, who developed depression. And we could see that those with olfactory dysfunction at baseline had higher odds of depression 5 or 10 years later. So if you have poor sense of smell at baseline, you're likely to have problems with your mental health over time. And interestingly, the signal was really in people who had no comorbidity, so healthier people, indicating that if you take someone who's healthy and you take away their sense of smell, those people are really going to feel it. It has a big effect on their mental health. And you can imagine, for all the reasons we talked about at the beginning, it really affects how you feel, your emotions, your mood, your memory. All of those things are combined there. And so it's showing us that sense of smell does have consequences on mental health. And this is the first study that's really shown that what's the sequence of that. Now, a few years ago, we published a paper that got a lot of attention, showing that your sense of smell is an indicator of mortality. And we showed that people who had a normal sense of smell 5 years later in our study had 10% of them were dead, whereas those who had poor sense of smell, 20% of the dead were dead 5 years later, and those who had no sense of smell, almost 40% of them were dead 5 years later. And this is controlling for all kinds of things that affect the risk of death. So the question was, why is olfactory function a marker, a signal of mortality, subsequent mortality? Now, it's very closely related to the development of Alzheimer's, and I don't have time to show you that today, but that could be one reason. And what we wanted to look at in this follow-up work is, how about that trajectory? How about that change in sense of smell over time? Is that a better predictor, right? Because you can, many people might have differences in their sense of smell. They may have had a car accident which bonked their head and lost their sense of smell. They may have been exposed to special chemicals. They could have other acquired reasons for sense of smell. So we wanted to distinguish sort of aging and rapid aging versus less rapid aging to see if trajectory of their smell loss would be a better predictor. And somehow I'm missing that slide, but I'll give you the bottom line. It turns out that trajectory of smell loss is indeed an even better predictor of mortality than just a single time point. So what we should be measuring is, how do people change over time? And I think that gets into the issue of categories, which is, if we can identify people who are having accelerated aging, in this case sensory aging, but you could extrapolate this to other fields, then those are the people we could focus on and really provide support to. So in conclusion, I wanted to just remind you that there are inherent and external causes of decline of sense of smell, both aging and genetics, but also pollution in the environment. So we have to look at that sort of holistically on the senses. Decline in sense of smell can signal future decline in physical and mental health and cognitive health. And this is such a rich project that we have the ability to address all of those different domains of health. And then we can use this. So we now have a tool. This is a 3-minute tool where we can test people and categorize their risk. And then we can identify people who we could intervene. So some of the interventions might be social support, letting their families know that, hey, these people are at risk for cognitive decline and poor health. Some of it might be for identification for trials. We think that one of the reasons why Alzheimer's treatments haven't worked is because we haven't started early enough. So if we could identify the people very early, then we could put people in those trials, design better treatments. So would be really helpful for enrollment in clinical trials. And then we really need to measure sense of smell over time. And we really need to measure sense of smell. So all of you can go to the eye doctor and get your eyes checked. All of you can go to audiologist or ear, nose, and throat doctor, get your hearing checked. It's pretty hard to get your sense of smell checked. You have to go to a specialized person. They have to have appropriate testing. It's very hard to access. And so we really need to have widespread smell testing so we can put that together with clinical data and understand better how the sense of smell declines. So changes in olfaction and other senses predict major health outcomes. They have an enormous impact on quality and quantity of life. I just want to leave you by saying, there's 1 billion pounds of wax producing candles. There's 10,000 different scents, 10,000. I mean, America is a wonderful country that it can produce so many choices of scents. It drives purchases. People use it within a week. I didn't know that. Like within 1 week, people burn up their candles, frequently in the living room, kitchen, and the bedroom. So, I'll leave you by just saying that, think about what smells make you feel happy. And that is really will capture how important the sense of smell is to you. And I thank you for your attention.
You don't get to leave yet, Jay. We have a couple of minutes for questions. I don't think Jay will provide advice on where to buy your diptyque candles, but on any other topic that you would like to raise. Yes, William.
Yeah, I have a question about this smell loss. Just sort of a tiny question. So one thing with COVID is people who had their sense of smell and taste, and then it was gone very rapidly. And I could see that that would have one set of implications versus someone who takes some time for it to happen. Is there any fundamental difference? And thinking of mood changes in particular, my son really struggled with the lost his sense of taste and smell. It did affect his mood almost immediately.
Yeah, Thank you.
Could you repeat the question?
Yeah, sorry, I'll repeat the question for everyone. So the question was, how about the timing and the rapidity of the loss? Does that affect mood, and how does that affect health? And he gave the example of his son who had COVID and lost his sense of smell quickly and had a big impact on his mood and mental health. So in COVID, we have this natural experiment where suddenly lots of people had a quick a pretty profound smell loss. Most people's sense of smell recovered, but some people didn't. And those people have had a huge impact. Many of them are younger people. I see them in my clinic and they have big problems. Even for the people who recover, they feel it all of a sudden, especially I think your son maybe is an example of this sort of low comorbidity, healthy people. They really feel the impact because they notice the difference. And then lastly, in terms of trajectory, we've done some other work in the Memory and Aging Project at Rush, showing that the trajectory of your olfactory loss over time actually can predict some changes, structural size differences in the brain related to both the olfactory regions and regions related to dementia. So that trajectory is very important, and the people who really plunge and go down quickly, those are the people that see the biggest change in their brain structure. Great, thank you.
One last question.
You mentioned training your sense of smell. You want to say something about that?
Yeah, so you may see in the news, there's this thing called olfactory training, and it's sort of physical therapy for your sense of smell, where you take odors, you can buy kits, you can use essential oils. I recommend people use spices, they're cheap, they're easy, and you basically practice with your sense of smell. So it's sort of like crosswords or Sudoku for your sense of smell. You're giving a challenge to your nervous system, and you're asking your brain to work at figuring out what it is and sensing that odor. And there's some studies in Europe that have shown that 30-40% of people, their sense of smell can actually improve after particular problems with their sense of smell. So easy to do, has no risk, and can be very fruitful for improvement in sense of smell.
Thanks, Jay.
Thank you so much.
Thank you very much, Jay. I would point out, in case people haven't noticed, that one of the critical sets of results that Jay talked about involved trajectories over time, and that's a fundamental part of NCHAP. So it's really quite different from doing a cross-sectional survey, no matter how big, to have the same people being followed over time and being able to track and identify sequences, what happens first, what leads to something else is really important. Elbert Huang, our next speaker, will talk about diabetes. And that's all I know about diabetes, but I expect to know more by the time Elbert is finished.
Great.
Right. Thank you, everybody. So I just want to first start with a question for the audience. How many of you know somebody, so it doesn't have to be personal about yourself, but how many of you know somebody who has diabetes? It's like it's basically 90% within the room. So I think that's going to be a good starting point to talk about how big a problem it is for population health and why policymakers care so much about diabetes. But of course, at a personal level, it's about the person and their condition. And so let me just start by telling you about the story of what is diabetes. It turns out that answer keeps changing. So if you were to ask a doctor 100 years ago, I think William had a picture of Dr. William Osler from Johns Hopkins in the early 1900s. At that time, we detected diabetes by its symptoms. So if somebody came with symptoms of diabetes, that's how we diagnosed it. Actually, someone talked about Aristotle this morning as well. In the time of Aristotle, there was diabetes then. Do people know how we diagnosed diabetes back then? Yes. If there were bees floating around, swarming around your urine, there was sugar in the urine. And so the early detection of the presentation of diabetes centuries ago was when people had excessive urine, glucose in their urine. And it was also marked by excessive thirst and weight loss. It turns out actually, if you are losing lots of blood sugar, in your urine, you lose weight as well. And that still happens to this day. People still do present with diabetes in that way. But obviously, our definition of diabetes has changed with modern technology as we've learned how to test people's blood sugar in their the sugar in their urine and then in their blood. So by the mid 1950s, 60s, we were already detecting diabetes by using sugar in the urine, and then we're shifting to testing glucose in the blood. And so how we detected diabetes, which is defined by elevated blood sugar, changed as technology changed. We gained more laboratory tests. But the big shift in how we define diabetes, moving from symptoms to actually predicted risk of future events, happened in the 1960s with the advent of epidemiology. So we started to define disease by future risk, not necessarily if you felt sick or were unwell, but whether or not you had a future risk of an event such as a heart attack or a stroke. So that is, how many people think that feeling good matters? I mean, that is why what William talked about is so important, because we've moved away from defining wellness and health just by how we feel, but based on laboratory tests. And so some people have accused scientific medical complex, pharmaceutical complex, of medicalizing conditions or states that don't need to be. Now, I'm going to argue backwards that actually diabetes does matter. And it is interesting that it turns out to be the most common, I think it's the most prevalent chronic condition in NSHAP. And it stands out actually in these studies that William talked about in the morning as this signal of future poor health. So it does matter if you have diabetes, even if it's detected by these blood tests. It predicts future risk of mortality, cardiovascular disease, dementia, but it also predicts the future risk of things that matter to older people, such as falls, dementia, chronic kidney disease. It's the second most common cause of chronic kidney disease, and people requiring dialysis. So it's a very morbid and mortal condition, so it does matter. And so I just want to talk briefly about the scope of the problem, which I started with. Almost all of you raise your hands knowing somebody who has this condition. And this is and this has happened in a very short period of time in human history. Basically, in the last 30 to 40 years, there has been a dramatic rise in the prevalence of diabetes in the United States alone. In the 1990s, 1980s, the prevalence of diabetes was only 5%. So only 5% of the population had diabetes. We're now at 10 to 12% of the population having diabetes. I'll give you can somebody name a risk factor for developing diabetes? What is a risk someone might have that? What was that? Genetics, of course, sure. Obesity. Thank you, Lynn. She's a plant in the audience. So I described this dramatic rise in the prevalence of diabetes. So that's the percentage of people in the population that have it. It's about 10% now. I've been here in Chicago for 20-something odd years, and the changes in the percentage of people who are defined as obese has actually been just as kind of shocking as the rise in diabetes, and they're connected. I remember 10 years ago telling a reporter that it was, I think we were tracking the rate of obesity in America, and it had reached 10 years ago of 30%. And I said to the reporter, there is no way that it can go above 30%. It's actually now today near 50%. So when I say it's a big problem, it's really a big problem at a personal level, but at a population level. So there has been something in the environment, in our food, in our lifestyles, and this is not explained by genetics. It cannot be explained by genetics because it's happened within a generation. This is a big problem, and one other thing to say is that the whole world is trying to grapple with this problem. Every single country in the world has rising rates of diabetes. There's really not one country that's untouched. And it's every ethnicity is touched by this condition as well. So it seems to not care, what color you are, where you come from. It's affecting everybody. And so I just want to talk about a little bit about some of the risk factors we believe are related to the onset, why we're seeing so much diabetes. So clearly, we think that something's happened to people's diet. There's something about the calorie dense foods that, unfortunately, the United States has helped to propagate throughout the world, that people have adopted. People, as their incomes have risen, have learned to eat foods that we like. And so that's clearly part of the story. But of course, many of us have changed our lifestyles. How many of you are looking at a cell phone or a laptop right now and sitting as you're listening to me? Oh, now everyone's looked up. Clearly, if you walk around, a college campus now, people are glued to laptops, cell phones, and clearly and video games. People are clearly not as physically active as they were decades ago. The last factor I want to mention is aging. So it turns out that just getting older is associated with a higher risk of diabetes. And so among people over 65 years of age, 25% of them have diabetes. 50% have pre-diabetes. That means 75% of the older adult population has some form of elevated blood sugar. Now, why is that? Were we designed evolutionarily to have higher blood sugars? Is there some kind of survival benefit of having higher blood sugars? I can't answer that, but it's clearly connected with aging as well. So as we all do a better job of living longer, we're going to have more diabetes and more chronic conditions like it. Okay, so that's probably a little depressing. But I'm going to move on to prevention and management of diabetes. And so I don't know, how many of you, could someone shout out, how do we prevent diabetes?
Eat healthy.
Eat healthy, exercise, what else? Watch your weight. Thank you. So and would your mother have said that to you? Please get out there, exercise, eat well, and watch your weight. Your mother would have said that too. So it turns out in the field of diabetes, we actually have turned your mother's advice into a randomized controlled trial. These trials were all published in the early 2000s. A trial done in the United States called the Diabetes Prevention Program, a Finnish trial, and then a Chinese trial also, all tested a lifestyle intervention in people who had pre-diabetes. And all three trials showed the same thing. You can prevent and delay the risk of diabetes by about 50% just by the things that we talked about: eating well, exercising, and losing and watching your weight. And just to be more specific, it's actually 7% weight loss. So if you lose 7% of your weight, and if you walk briskly for 150 minutes per week. So if you just remember that, 7% weight loss, 150 minutes per week of brisk walking is a recipe for preventing diabetes. So we can prevent diabetes pretty dramatically with those interventions. So the biggest change, though, in the last 10 years has been in how we manage diabetes. And that's not entirely surprising because of the heavy investment in the pharmaceutical industry that we commit to. I mean, it's probably not the way we would want the system to go, but we have invested heavily in the science of medications designed for diabetes. And so this has been probably the most dramatic change. 20, 30 years ago, there were only 3 drug classes for managing diabetes. Now, if you watch the nightly news, you probably know about all the new drugs that are available to lower your A1C. And so now we are up to 10 different drug classes available for diabetes management. And many of the drugs that were studied in the last 10 years have had dramatic benefits, improving reductions of cardiovascular disease, but also preventing kidney failure as well. And these new drugs are really probably closer to matching our natural body's physiology, and that's why they're doing a better job. So the downside of these new drugs is they're extremely expensive. They're all brand name. They're going to be expensive for a long time, and I think Dima will talk a bit about the complexities of dealing with multiple medications. So when we take care of older people with diabetes, we're oftentimes faced with the question of how many of these medications should we be using? Is it going to be beneficial for this older person? And the evidence basically starts to drop off as people get above the age of 75. Most of the randomized controlled trials of diabetes actually excluded people up to the age of 65 until around 2004, 2005. Since then, people in their 60s have been enrolled in these trials, but people in their 80s, 90s, and 100 are typically not in these randomized controlled trials. So we have to extrapolate the data that we have from these trials to taking care of older people who are typically more complicated than the people that are included in randomized controlled trials. I will just make one comment about NSHAP. NSHAP was pretty critical in a study that we did looking at older people with diabetes and creating a classification system of those older people. And we found that about 50% of older people are relatively healthy with only diabetes and no other condition and are very well. But the other two categories are relatively sicker. One group has a lot of heart disease. Another group is relatively frail and is obese. So those two groups, we believe, need to be treated and thought about differently than the group, the larger 50% that is relatively healthy. So I want to end with a couple more things. One is about, I'm sure, I get asked by patients all the time, am I going to have to take medications forever? Can this be cured? So that's kind of like a big, I think for people, this is what really matters to them. Can they be cured of diabetes? And it turns out that there is, remember I told you about the 150 minutes a week and the better diet and the diabetes prevention program. They did that same program basically in people with diabetes and in a trial called Look Ahead. And during the course of that trial, about 20% of people were able to come off medications for blood pressure, diabetes. And so that proved that you can actually, if you define cure as not being on medications and having well-controlled sugar, it can happen, but it's a bit rare. It's hard to do. The most surefire way, of course, unfortunately, to cure diabetes is actually to undergo bariatric surgery. But I would say we don't have a cure for type 1 diabetes, and we don't have a definitive cure for type 2, but I think there's some hope in terms of lifestyle. And I'm going to just end by saying that obviously this is still, this is a big problem, and you'll notice that the cost of medications is, this is a segue to Dima's talk. The cost of these medications does matter. And you'll notice that in the Inflation Reduction Act that was just passed by the Biden administration, that they've picked out insulin as a drug where there's a cap on how much people need to spend. I think what's going to happen next is, can we expand that benefit to more medications? Can we control costs of medications for the whole range of medicines? So I look forward to any questions you have. Thank you very much.
I think we can look forward to questions by standing here. So if you could speak loudly with the question, and if necessary, we'll Elbert will repeat it.
When you were talking about how much the increase in diabetes, were you referring to type 1 as well, or only type 2? In the prevalence?
Both are actually increasing, but the vast majority of diabetes is type 2, so it's 95%. So I'm talking mostly about obesity-related and aging-related type 2 diabetes.
So is there any?
But there is actually more type 1 diabetes also happening too.
So you can understand the increase in the prevalence of type 2. It's fairly obvious, but is there any good explanation for the increase in the prevalence of type 1?
So so type 1 diabetes is the form of diabetes where the part of your body that makes insulin is actually destroyed by your own body. So it's the auto destruction of your insulin producing cells. And they're, the proposed explanations are related to environmental changes, possibly toxins in the environment. There's a rise in general of autoimmune diseases across the board, so it may be tied to that as well, but we don't know entirely. Yes, William.
I'm wondering if you could comment, Elbert, on this pre-diabetes state. There's a lot of, some people are skeptical of what that really means. Others feels like medicalization. Others, you might say, it's early identification. There's a rise in that's treated them. Can you just comment on what the status of pre-diabetes is right now?
Yeah, I think I mentioned that there was actually a science article a few years ago where they raised the writer talked about how prediabetes was basically completely constructed by the American Diabetes Association, the NIH, and the pharmaceutical industry. And I think there's a little bit of truth to that, but there is some risk associated with prediabetes and future events. And in general, it is actually quite valuable to know if you have it, because it turns out to be we can make changes when people have prediabetes, and we watch people actually fluctuate. Actually, NSHAP allows us to do this. We watch people fluctuate between prediabetes, diabetes, and back to prediabetes and back to normal, actually. So I think it's actually an early stage of dysglycemia that we can actually intervene on. So I think, to me, it's good to know about, and we have the diabetes prevention program and other trials like it.
Is there a formal definition now that's widely accepted for it?
Yes, there is and all these diabetes can be defined like 3 different ways, and so can prediabetes by A1C test, fasting sugars, but also a response to basically a can of Coke.
Thanks very much. So I'm delighted that these two talks have not just described to us how aging leads to general deterioration, but in both cases, some positive indication there may be some things you can do about it, although truly these remedial efforts will die out after a while, as we all will. Our third talk is by Dima Qato, who's our pharmacologist. I mean, she's not really our pharmacologist. She's the pharmacologist who kindly works with us. The title of her talk is suitably terse, medications. Having grown up in a tradition where people try to avoid taking medicines as much as possible, I'm delighted to find, like mother's advice on diabetes, that it turns out that avoiding medication as much as possible is a pretty good idea. And Dima will tell us why.
Yep.
Well, thank you very much for inviting me. It's really kind of exciting to talk about a topic that really started with NSHAP almost, I don't know, 15 years ago when I first started working with the medication data. And at that time, I was a PhD student at UIC. And one thing that I'll mention is the value of NSHAP. Even now, it's really hard to find a data set that captures medications people use and not medications people are sold or are prescribed. And we know there's a huge discrepancy between the two in terms of prescription medications, but also over-the-counter medications, dietary supplements. I mean, if you just go to any store, it's hard not to buy, supplements when they're like, oh, it makes you smarter, makes you prettier, makes you like wiser, maybe at some point, or sleep better. It's really hard to kind of building off the medicalization of risk and just the biomedical model. It really serves the market, and that doesn't really serve healthy aging, right? So I'll be talking about polypharmacy specifically and how the adverse effects of medications. Hopefully this is better. So what's polypharmacy? There's many definitions, but I define it as just kind of using multiple medications together, right? The cutoff is usually 5 medications or more because it was tested in the past and it predicts increased mortality risk. And we know this is using NSHAP data, what you see here at the plot, that it's increased the use of multiple medications, right? At least, among older adults over the age of 57, at least 80% use 2 or more medications, and at least a third use 5 or more. And that's, a problem when you think about what could happen if you're using multiple medications, even if you're using them to treat diabetes or hypertension or prevent a heart attack or to treat depression. You can have drug-drug interactions, and that's kind of the clinical way I think physicians and pharmacists often refer to the problems of polypharmacy is that some combinations are known to increase your risk for certain adverse drug events, like QT prolongation, serotonin syndrome, but also bleeding risk. And there's also adverse effects of medications. So, we know certain medications have an increased risk for something. But what's really not known is how these side effects kind of synergistically impact outcomes or health or illness. And that's, another value of NCHAP is that, we measure certain outcomes that are not really tested when a drug is approved, right? And it's only post kind of approval that we discover things like even cancer. Oh, wait, this drug causes cancer, but also things like more kids are committing suicide when they're on this drug. Hey, what's going on? But those are adverse effects. They're not really captured in your drug-drug interaction kind of, when you're interacting with a patient, you get a red flag that, hey, there's a major interaction. Those adverse effects of using multiple medications are captured in the clinic or in the pharmacy. And there's other types of issues that arise from polypharmacy that are drug disease, drug alcohol, drugs, if you smoke, there's certain side effects that you're at increased risk for. The same with, if you drink regularly, you're at increased risk for certain adverse events. This is, our work using NCHAP was really impactful, and hopefully will continue to be impactful because it really uncovered a hidden problem with the use of medications, the concurrent use of medications, polypharmacy, particularly in aging, because the expectation is you're getting sicker, you need more meds. But that's not always true. Sometimes you need less meds to be healthier. If you consider medications, not only how they work to treat a certain illness alone, but how do they treat you as an individual in terms of your personal health and wellness, not your disease state. So it's an important problem. I would say it's a big problem. And it's important because many of the medications, they don't just treat certain illnesses, but almost all medications have side effects. Some have really serious side effects, including cardiovascular side effects, which is the leading cause of mortality in older adults and leading cause of disparities in older adults. And these are common medications like NSAIDs. I mean, they have a black box warning. Proton pump inhibitors, you can buy them over the counter, just like you can buy NSAIDs like Prevacid and Prilosec. Bronchodilators, many of them have warnings about cardiovascular risk. And the FDA is monitoring these risks, but just for the drug or the drug class, not how they're used together. And there's some work we've done, which I won't share here, but really showed that for older adults that do not have a history of cardiovascular disease, those that take more medications that are not indicated for the prevention or treatment of cardiovascular disease are at increased risk with each medication they take of having a major adverse cardiovascular event, almost twofold. So it's polypharmacy, even in terms of just cardiovascular risk, is an important public health problem. And, in addition to kind of cardiovascular disease, there's also many medications that cause depression as a side effect, sexual dysfunction or sleep problems. And these are just kind of, snaps from the news and journals. But we also did some work around depression and medications with a black box warning that they increase your risk for depression or suicidality. And what we found was that the more medications you're on, again, even if you don't have a history of depression, and if you do have if you've been diagnosed with depression, the more medications you're on that cause or have a known risk to increase depressive symptoms, the more likely you are to report being depressed. Again, these are questions you can really only answer with NCHAP. For our specific study, we used NHANES because it was more current, which is why we were able to publish in JAMA. But the point here is that polypharmacy not only leads to preventable adverse drug events and hospitalizations, which a third of hospitalizations in older adults are due to adverse drug events. And most of those problems are related to medications used in combinations. And you see here, there's a lot of focus on physical health, like drug-drug interactions, including in my own work. And it's important because it's something you can kind of do something about, or try to at least, in terms of the intervention, the patient encounter. And there's tools to help you do that right now that exist in our electronic medical records or our systems in the pharmacy, where you could identify these known interactions, which we know are contributing to avoidable hospitalizations in older patients. But what's really unknown is this kind of the social and behavioral and mental health aspect of polypharmacy, which we know is really important. Depression rates are growing in the United States, particularly among older adults. And, you know, even social things like sexual dysfunction, sleep problems, and all these issues, I argue, could be related to medications. But we don't see labels. Do you ever pick up your medication? Oh, it may make you, have difficulty sleeping, or may increase your risk for depression. I'll tell you, eat it with food or don't take it with alcohol, right? And other side effects, but these make you forgetful. People don't know. There's really limited awareness unless you read the 2-page medication guide or label that this drug could make you forget what you did 2 hours ago if you take it for a few days. And that's what, I mean, there's a lot of work right now around just, the relationship between certain types of medications, not necessarily the side effects, but specific classes that's based on the biomedical model, and dementia or cognitive impairment. And some of the areas that we're exploring are around just, sleep, cognitive impairment, as well as depression, and how medications could contribute to that. But that's a work in progress. And I think it'll lead to really important insights around just these deprescribing efforts that are going on. I think the goal is to kind of figure out, what do we stop in older patients, right? Some drugs like insulin or the newer diabetic medications are critical in preventing mortality and improving health outcomes. But maybe other drugs, and one of them is like statins, right? Which I'll talk about a little. After a certain age, they really offer no benefit, and they actually increase your risk. And right now, statins, which are indicated for primary and secondary prevention of cardiovascular disease, are not recommended for people over the age of 75. And I support that, especially given what we found in NSHAP in terms of what are the most common drug combinations used in older adults. And we found that 1 in 25 people are using these combinations. And these are potentially fatal major interactions. They're not mild or minor or moderate, they're severe, and they can potentially lead to fatalities. And you see here, I'm listing these because, for people that are interested in knowing, what are we talking about? These are prescription combinations. And this is based on NSHAP. It was published in JAMA Internal Medicine almost 5 years ago or 4 years ago. And they're drugs like amlodipine, used to treat hypertension, simvastatin, a statin used to prevent cardiovascular disease, warfarin, anticoagulant, used in patients with AFib to reduce clots, simvastatin, right? These are combinations people actually use on a national level using NSHAP data. And these are prescription drug combinations. Again, amlodipine and clopidogrel, an antiplatelet. But when you see these combinations, they're frequently used, but they have these kind of risks, these adverse effects that are known drug interactions that could lead to hospitalizations and potentially death. So they're very important to potentially avoid or replace, for example, amlodipine, or I would say simvastatin. I mean, is there a need, depending on this patient's risk factor, for them to be on a statin? I mean, all these efforts to reduce, reduce cardiovascular risk at older ages, if we're increasing statin prescribing has kind of increased dramatically in the last 10 years. It's kind of plateaued, but increased during this time, it more than quadrupled in this age group. And what we found was that, okay, maybe good, but actually no, you have to consider statins in combination with other drugs because they have a lot of interactions, just like warfarin does. And you want to make sure you weigh that benefit with the risk given the totality of medications people take regularly, including non-prescription drugs. And I think this is what's really novel, something we can't do with NHANES, something we can't do even with like claims data or other kind of insurer-based data sets that are often used in the pharmacoepidemiology and policy world is kind of what are the over-the-counter drugs or supplements people are on. It's a huge market, right? It's $1 billion industry. And they're not really accountable and regulated by the FDA like prescription drugs, so they kind of get away with more. And what we found was, they're still being used commonly in older adults, and it could be dangerous, particularly given what it could lead to, like bleeding. Gastrointestinal bleeding or hemorrhagic strokes lead to death and hospitalizations. This is, one of the most common reasons older adults go to the ER and get hospitalized in terms of adverse drug events, bleeding. And when you look at the drugs contributing to that, it could be these combinations. And warfarin and aspirin. And now what's interesting about aspirin, it's over the counter, it's very cheap, and it's really not recommended in older adults at all. I think now the policy keeps on changing depending on your groups, and that's why the medical system, the biomedical model is difficult to follow because it's changing depending on what you read. But also naproxen, which is over-the-counter NSAID, has a black box warning, which is the most severe warning the FDA issues for medications, often reserved for prescription medications, but naproxen actually has a prescription strength, which is why it has a black box warning, but it's used with warfarin. I mean, that's like, for any doctor, if a patient comes in and and they actually tell you what they're on, they often assume that you don't care about their over-the-counter drugs and dietary supplements because you didn't prescribe them, but you should. And I think most physicians and pharmacists care. I mean, they might not ask, but they care. It could really increase their risk for bleeding. I mean, I don't know if you just ask anyone what their medications were on. I mean, I do this all the time because people always go to me and I'm like, this is, you have bruises. I mean, what are you on? Well, I'm on garlic. I'm on ibuprofen. I'm also on all these other drugs. And bruising is a sign of like potentially bleeding. Or they have diabetes and they do the finger sticks and they don't stop bleeding for an hour. So you kind of look into what they're taking. And if you know me, I usually blame the medications. And sometimes I'm right, depending on who I'm talking to, not with my mother-in-law, but who's like a total overuser. So she goes to her son, not to me, who's a physician who overprescribes. So, and thinks I'm like too nervous around medications. But anyway, so these are kind of, then you have the supplements. I think I have them combined here, right? Omega-3 fish oil. I mean, this is kind of the part of this paper that got someone to write a letter to the editor, like, hey, you guys are saying bad things about omega, but it's actually good. And it was the manufacturer of the leading omega-3 fish oil. But we responded, my colleagues and I, and we're like, there's really no benefits to this, especially in older patients. If anything, it can increase their risk for bleeding. So, and there was a Cochrane study that looked at that and kind of supports our claim, which obviously we didn't make this up. This is based on Micromedics, which is a drug interaction software. So all these adverse effects are not Dima's adverse effects. They're known drug-drug interactions and the adverse effects they cause. But omega, since I think there's some studies that show that it's beneficial in certain groups of patients at high risk, or I don't know, but it still increases your risk for bleeding, right? So that adverse effect is there. It's an interaction. The extent to which that bleeding risk outweighs the benefit of omega, I think is still a question that needs to be answered. But it's easy to get. I mean, it's always buy one, get one free at any Walgreens or CVS. Yeah. Right. I think the first study we did in NSHAP had another group of drugs, the chondroitins, which were also buy one, get one free at that time in the early 2000s, but they're no longer used as much because I think the risk benefit in terms of more risk than benefit has been increasingly recognized. And omeprazole, which is a proton pump inhibitor that used to be a prescription. I'm going through these because I thought, hopefully it'll be beneficial for those who are not aware of these medications. But is used, it's an anti-acid, used for GERD, regurgitation, acidity in the stomach. It's a serious problem, but for some patients. But in older patients that are on clopidogrel, that's usually a high-risk group. That risk-benefit balance, I think there's a reason why there's an interaction, and that interaction is, and it's been proven repeatedly. Proton pump inhibitors increase your risk for a blood clot. So if you can avoid omeprazole, whether it's prescribed or you're getting it over the counter, it's probably better to do so and discontinue it slowly. One last thing I'll kind of, and one combination that I found most interesting at that time was niacin, atorvastatin. And what I think many people don't know, and this goes to show you the medicalization of just risk and disease and just how the pharmaceutical industry influences the FDA. So niacin, atorvastatin combination, right? It's a known interaction. It was actually sold as a combination pill. So you didn't have to take niacin over the counter as a supplement and get atorvastatin, and the doctor didn't know about it, right? It's actually approved. It's ready to be prescribed as a combination. I think it was atorvastatin or simvastatin, it kind of, but, you know, a year after our study, you know, surprisingly, not to say that it's because our study, the FDA discontinued or withdrew the drug, or the manufacturer withdrew the drug, but it's no longer available. But the FDA approved a drug, like it's one pill, it's a combination pill that has both medications in it, that has an interaction. You know, I think that just, there's a lot of lack of oversight and understanding of the importance of combinations, whether they're used separately, together, but, you know, as separate medications or just in kind of a single pill. So I just have kind of some next steps, or just, you know, tips for patients in terms of what this means to the community is, you know, it's really important to tell your doctor or your pharmacist of all the medications you're on. I mean, we say this in our papers, and you know, just when I talk to people all the time, is you can't, I mean, the doctor and pharmacist only know what you tell them oftentimes. And if you're lucky that they ask, that's great. But if they don't ask, you tell them. And we know a lot of providers don't often ask patients. They might tell them, oh, is this your current list? Like I think was mentioned earlier, whatever's on the record, which oftentimes is not equal what you take at home. So make sure you tell your doctor all the over-the-counter medications, dietary supplements you're on. And don't start a medication without checking whether it interacts or has certain side effects that are important to you, and how that works with other medications you're on. And I think most importantly is don't stop. Even if you discover these things, that there's an interaction and you're already on a medication or a medication combination, you really can't stop it right away, and you need to check how to stop it. You know, part of some of the work that we did using NSHAP that was published around polypharmacy and drug interactions, particularly around depression. There's a lot of patients, I would get emails from just, you know, the public as a public pharmacist, and they would ask me, oh, so, you know, I realized after I read this article in the New York Times or USA Today or whatever, that I'm on 3 of the medications you listed. Should I stop them? And my doctor prescribed them years ago, but now I remember that, you know, a few weeks after I started, I felt really down, and I still feel really down. And, you know, my response is usually, well, you know, don't stop anything without, you know, which is what I should do, right? I don't want to be liable for anything, because there are some hazards to stopping medications suddenly, especially if you've been on them for years, in terms of your risk for clotting or rebound effects. So, you know, there are problems that really affect community, and people, including in the healthcare community, are not aware of that. Yeah, we think of medications as treating an illness, but oftentimes those illnesses and diseases are manufactured, created, invented. You know, like indications are always expanding, whether it's a lower threshold for hypertension or diabetes, or even for depression. You know, you want to make sure that that the medications offer in combination more benefits than they offer risks, especially given the patterns of mental health and social well-being in the US. Thank you.
Thank you, Dima. We've run a couple of minutes over time, but I would like to give us just a couple of minutes for a question, including mine. And my question is addressed to you, Dima, but also in a way to Elbert and to William. So one of the things that William said earlier on was this move from looking at causal relations to looking at something else. in looking at clinical trials versus other ways of thinking about things. You've talked about the challenges of taking multiple medications, each of which may be directed at a particular thing. Now, first of all, I don't think clinical trials are a good test of causation. Clinical trials are testing cause for something you don't care about, like what would happen if you give this medicine to someone you're not likely to give it to. So as a future patient, I hope, perhaps not, or what should we be looking at? You know, it's clearly impossible to test in formal trials all of these combinations, right? It's clearly not sensible for any of us to look at this and say, oh my God, I can decide for myself which of these things is going to be relevant. But the whole process of developing and testing doesn't answer any of the questions that we want answered. So I just like in the next 3 minutes for you to tell us the solution. So Dima first,
Yeah.
of course.
So,
Yeah, it's on.
yeah. So, I mean, I think that's the question a lot of pharmacoepidemiologists are trying to answer, especially those interested in polypharmacy. And, you know, I think there are efforts to kind of look at combinations, particularly using machine learning, which I think has its own biases. But I think what's important first step is to discovering those combinations that are common. So we don't go and develop trials or studies that focus on irrelevant combinations from a population level, right? We focus on combinations that matter to more people or combinations that matter to certain subgroups of those people. And they're not being studied, right? So like some of these combinations, these are drug interaction combinations. These are studied. That's how I was able to know kind of what the adverse effects were. But I think what's more important are these other aspects of drugs and drug side effects that can be measured in NCHAP, but also, you know, depression is measured in clinical trials. It's captured in some electronic medical records. There's certain databases you can use and leverage, but you need to know what medications to look at. And that's, I think, one of the hardest parts, where there's less consensus. And, you know, I often rely on the FDA labels and micromedics, but there's some discrepancies.
Elbert?
Can you hear me?
I can hear you, but maybe you should use a microphone.
One minute. I mean, part of the answer is, I think, it's actually the use of real world data. So we actually have systems where because of the way people prescribe medications, sort of by accident, sometimes on purpose. And if we have data on what happens to those people, we can actually find rates of, like, we can find basically the connections between combinations that are bad, how often it happens. And actually the FDA has a project called the Sentinel Project, which is a bunch of different health systems that contribute data. And it's the purpose is for drug monitoring. But actually for the bigger picture, though, related to NCHAP is not all people in trials are representative of older people in the real world. And so that's why the real world is actually really important for studying. Even if a drug was studied in a trial, we need to be able to see how that drug works in real people.
The last word for William, since
Maybe one standing between us and lunch, of course. And don't worry, Colm, we're not going to enroll older people in trials anyway. It's too hard, so we won't have to do trial-based things.
it's not all about me. You want to use a microphone?
Sure. So one of the things I learned from Colm, so that's always a good way to answer Colm, is something he said more. I think it's important that you have a comparison group that's relevant in studies. And if it's not a randomized trial, that's some sort of way of comparing this to a relevantly similar group is what I always emphasize when I talk about even the real world data, where I'm a little worried about garbage in, garbage out in the real world data, that it's not measured very carefully. So I also think we should pay attention to something like NCHAP, because you need it measured consistently and well to get a good answer. So I think whatever trials we have, those are important. I do like the new cluster randomization things that we're doing in the behavioral health, where we say, here's a practice that does it this way, here's a practice that does it a different way. Let's compare the two. And if there's differences, it's probably how they're practicing. So I think there's ways to get answers.